Good afternoon, everyone. Hope you can all hear me okay. You're all muted at the minute, but thank you everyone for joining us today. My name is James Williams. I'm a director here at BW Healthcare Surveyors. I'm delighted to be joined today by Jennifer Lewis of Mills and Reeve Solicitors. As you know, this webinar is based around space optimization for Neighbourhood Health, and we'll be exploring some of the aspects around the background behind Neighbourhood Health, identifying some key questions around the legal framework and some practical considerations, and also some more general aspects relating to space utilisation within the general NHS estate itself, and with the move obviously towards integrated community-based care, making the best use of existing space has obviously never been more important. We should hopefully have a bit of time at the end for any questions, and if you do have any, please pop them in the Q&A tab, and we'll try and get the work through to those at the end. If we don't have time, we'll try and follow up with any, and this is being recorded. It will be sent out to everyone who sort of attends today. During the course of the presentations, if we pick any questions up, we shall try and pick those up as we go. Without any further ado, I'll pass you on to my colleague Jennifer Lewis. Thanks.
Thanks, James, and welcome everybody. I can see there's still some people joining as we talk, so I'm just going to do a brief introduction before I get into the nuts and bolts of it. So my name's Jennifer Lewis. I'm a real estate partner at Mills and Reeve. I advise a lot of GP partnerships and other primary care providers. I also advise on real estate across the healthcare sector. This first slide is just by way of a sort of a brief introduction to our team. Rob leads on the commercial, he heads up our primary care team, he leads on the commercial corporate side of things, and I lead on the real estate for primary care. But we have specialists within all of our 7 offices across the country who are working within this sector, and you can sort of see the detail of some of the areas of that we advise on there. So that's the details of the team. You've got our details there, and you can take those away, and I'm sure you'll be able to get hold of the copies of the slides afterwards if you need more information around that. So just briefly looking at what I'm going to cover today. So I'm going to look at different kinds of occupancy. I appreciate that a few people on the call, and people are likely going to have different forms of tenancies or ownerships, and we can briefly try and sort of capture all of the different types, the effect on those different types of occupancies, the legal considerations for each in terms of the optimising space utilisation, which is obviously the main thing we're here to talk about today. What could you be doing now to prepare? What the challenges are going to be, and then also a bit of horizon scanning and looking to the future. By way of background, I suppose, before we get into it, I was going to say that up until the last couple of days, the only information that we had coming out of NHSPS in particular around, how we're going to implement Neighbourhood Health, how these big headlines around Neighbourhood Health centres, how is that going to be done? The information that we'd had up until the last couple of days was around utilising what we already have, which is why we thought this would be a great topic to talk about and look at how people would be able to do that within their own premises. Of course, now there has been some additional guidance which has come out, setting out a bit more detailed information for ICBs in particular about how that programme for neighbourhood health centres within the estates world is going to be taken forward. The good news for me in particular, in terms of having to rewrite this, is that the number one priority is that it's still very much that number, that sort of first point is looking at what we've got. Do we need to refurbish it, repurpose it? Can we do something with the existing buildings that we already have? So that sort of sits within what I was going to talk around anyway. We know obviously there's going to be some new neighbourhood health centres in the pipeline, but the quick wins around that existing build. There are lots of stats that we've seen out there, you'll all have seen them as well, around the underutilisation of GP premises. I think we take those with a pinch of salt. I'm sure there'll be people on the call who think, well, I haven't got any spare space at all. Someone 200 miles down the road might have a lot of spare space in that premises. It's not going to help me. So, sometimes, the numbers don't tell the full picture. There may be clinical space, non-clinical space. We can't mix up the two anyway. So, it's not as easy as saying we've got this underutilised space, why aren't we using it? But on saying that, it's incumbent, I think, on all practices to start using their buildings more effectively. Even if you're not creating a neighbourhood health centre, then you're still going to be working within the neighbourhood health ambitions. It makes sense from a cost perspective for you and for your patient perspective as well. And doing this, I think, there is a big headline, which I think that is sort of within this, the new guidance, which has come out in the last couple of days around future proofing. The report states that across the country, there's 3 million square metres of primary care and community care estate, and it does say much of that is not best suited to providing modern patient care. And so where this is the case, then it needs to be decommissioned and disposed of. So I think there is a point here, isn't there, about sort of keeping up with the standards that are going to be required and sort of sitting within that wider health estate as well. So this next slide, excuse me, it looks at different kinds of occupancy. Those top four, they're all leases essentially, but the identity of your landlord, I think, does make a difference. So you might have a different kind of lease, and then in terms of what the pressures on you, or what the requirements and expectations might be, will differ depending on who that landlord is. And then lastly, own premises, which obviously just will have, again, different pressures, different concerns. The picture there actually is it's an architect's drawing, I think, of premises that we're involved with. We're acting for the GP practice there. It is a new development, that's why it's not a picture of the actual building. And in that one, the GP practice has taken the lease, NHSPS taken the head lease. So, these things are done in a number of different ways, and I just thought it's nice to illustrate that as well. So bearing those points in mind, looking at the details of what do you need to be thinking about if you are looking at sharing parts of your premises? Is it possible to share parts? And I suppose the first point I wanted to address really is what we mean when we talk about sharing. And I think there's probably two different kinds of situation that we're thinking about. So one will be where it is a true, what I would call a true sharing arrangement, where perhaps you're operating during the day and then someone else is coming in and using the premises in the evening for out of hours, for example, or a service provider is coming in and using one of your rooms one day a week. That's a sharing arrangement. It is very different, and it is dealt with legally very different from where you have a third party that comes in and uses part of your premises every single day, and you're not able to operate out of that because that is their room or that is their part of the building. That is a leased landlord-tenant kind of situation, and it is, as I say, dealt with quite differently. If it is possible to share, you need to basically, if you've got a lease, you need to have a look at your lease, because the lease will tell you whether you're able to do either of those two things, the informal sharing arrangement or the more formal sort of landlord-tenant, or in that case, it will be a subletting kind of arrangement. And your lease will set out parameters around how you can do both of those things. And it is likely you're going to need to get your landlord's consent to do that as well. So, it is very important that you look at the lease and you're aware of the terms of the lease and that you comply with them, essentially. But yes, it is possible to do that, but it very much depends on what your existing lease says. It's likely you might already be sharing already, and if you are, I would suggest that you just have a think about that and whether or not your lease, number one, allows it, if your landlord knows about it, and whether that's informal, you can still put in place some sort of license arrangement, not as formal as a lease. It deals with this kind of not 24/7 situation, but it just makes sure that everybody knows what those terms of that agreement are. And I would say that was quite important. If you are an owner occupier of a building and you're thinking, well, actually, I'd like to get these services in, well, obviously you've got a bit more flexibility because you haven't got a lease. It's your building, you can do what you like with it. But what you do need to think about, well, I suppose, two things that you need to be really aware of is, number one, if you've got a mortgage, you need to just make sure that your lender is aware of it and is okay with it, because likely the terms of your mortgage will say that you need to let them know and get their consent to any sharing or underletting arrangement. And the other thing that you need to be aware of is that if you have somebody in occupation of the premises, and in particular if they're there on a sort of exclusive, what you'd call a lease landlord and tenant arrangement rather than that sort of informal license arrangement, then they could end up getting statutory tenants' rights, and you're going to struggle to get to remove them from the premises should you wish to at some point sell it or use it for another purpose, or just not have that tenant in anymore. So if you are in that kind of situation, you do need to make sure that you put in place a proper lease. I would say that also goes, and this is just a by the by, if you were if you have retiring partners that happen to own the premises, they also need to put a lease in place between the property owners and the partners now running the practice, because they're in exactly the same boat as well. So just to make you aware of that. The next question is whether your landlord can require you to share any part of your premises, and if you've got a lease, then they cannot, because the lease sets out that which part of the premises is yours, and you're for a term certain, and that's the arrangement for as long as that lease exists. So they can't, but you may well agree with your landlord, particularly, yes, in this case it's likely to be NHSPS or CHP as a landlord. You can agree with them that actually, maybe you don't need some of this space, or you're going to let somebody else use it. I would just make sure that is documented, because if they're using it but you still have the lease of the whole, then you are essentially still responsible for that area, and it could get extremely complicated in trying to work out how that works. So either they need to be a subtenant and have an actual lease in place, or you need to reconfigure your lease so that it doesn't include that area, which I would say is the it's the safer option for you, basically. So the next question there is, what's the effect on your rent reimbursement? Well, as you'll know, you can only get the rent reimbursement for the parts of the premises which you're operating and providing the GMS services from. So, but obviously the premises cost directions does envisage, there being multi-use, multi-let buildings, and how you can deal with that. What you just need to make sure with, and I know James is going to cover this as well, is that there's no double counting in terms of the rent reimbursement, that any agreements that you have with any subtenants or license arrangements, however it is you're doing it, just reflects that and is back to back with your arrangements, and that you're not then caught out if somebody leaves and your reimbursement has been reduced because of their occupation. You need to make sure that all of this is captured so that you don't lose out because of this arrangement. What's the effect on your service charge? Well, if you're an owner-occupier, you haven't got a service charge in the first place, but you need to put one in place. So, that's something to think about, and obviously you need to be able to manage that. It would be within your lease or within your license arrangement, and just making sure you can recover the costs, and that you're not out of pocket by having this third party in occupation of your space. If you have a lease, then you need to look at whatever arrangement you've got in your lease, just needs to be passed on. And again, there's just that the risk point here is just making sure that nothing falls between the lease and the sublease, and that you can recover all costs in that way. Once you enter into this arrangement, can you get back out of it again? This is the difficulty, isn't it? Because you think, well, I don't know how long I want to commit for. Once I've signed up to this, am I stuck with it? To a certain extent, with a lease, yes, you are. Obviously you can have break rights and things like that, but the lease is there for a term of years, and pretty much the case is that is how long the lease will be, unless you mutually agree that you don't want it to go ahead. That's outside of the lease. With the license, then usually the license, the big difference between the license and the lease is that you can, there will usually be exit details within the license itself, and that's the point about it. It's just much more flexible than a lease, and that sort of goes on to sort of how flexible can these arrangements be. A license, if they've got, you know, such and such a room on the ground floor, the license usually allows for you to move them and go, actually, to be honest, we want that room now, we can move you upstairs to this room. Things like that is much more flexible, whereas the lease is, this is the area you've got, this is the time you've got it for, and these are the terms you've got it for. A license is much more flexible than that. So that's a bit of a whistle-stop tour through the various legal considerations about, you know, if you're looking at some empty space, what do I need to be thinking about? Those are the things you need to be thinking about. I know James will touch on this as well, but I would just mention ICB approval, and obviously any arrangements that you're making just need to be signed off in this way. But is there things that you could be doing now, even if you've got absolutely no plans to do this? I would still recommend some of these sort of forward planning points to be aware of. And to be honest, I think I've said this in every talk that I've ever given to GPs, is that, I know you're the same as well, James, is that people need to be looking at their lease, they need to be looking at their land registry title, they need to make sure that the names on those documents and partnership agreement as well are the partners that are currently the partners in the practice. And if they are not, it is going to cause you delay in granting a sublease, granting a license, doing whatever it is, selling, getting grant funding. All of these things are going to be extremely time delayed if you've then got to sort out something with the retired partners. I've just put some sort of examples really of the sort of thing you might be looking at in terms of plans. And I would advise you as well, if you're looking at a lease, have a look at the lease plan. If you've been in those premises for a long time and you've got part of a build, sometimes, you know, the red line doesn't accord with what you're actually doing on the ground. It's a really good idea to know that it does. And to rectify that if it doesn't. Same with the title plan. I actually recently had some people getting utilisation and modernisation funding. They looked at their title plan and actually it didn't have the red line, didn't go right the way around the area that they were extending into. And so we had to delay the funding because of that. So things like this will cause a delay, but it's actually super easy to resolve. So I would, well, when I say super easy, they're easy to resolve, but not if you're up against a time deadline of trying to get your UMF funding over the line. Much easier to resolve it before you get into any of these kind of things. So I would strongly advise that you start to look at those. Anybody look at those.
I came across a similar situation recently where we were dealing with a lease renewal, and the demise over the years had changed. And yeah, it's the same point we made. The extent of the actual lease itself had evolved somewhat. Yeah, on the ground.
Yeah, exactly. Totally the same. I was talking to a practice. They were in a CHP, a lift building, and we'd had so many discussions about what the shared spaces was, you know, who could go where, and their waiting rooms and all this kind of thing. And then when I was talking to them, they're like, "Oh no, we just use that room now. You know, that's just part of our rooms now." And it's these things, as you say, and especially because some of these leases are very long, that they evolve over time. So always be keeping an eye on those things. If there's changes in the practice, make sure that they're being reflected in the title. It's not just a sort of a side event. Thank you. So I've mentioned some of the challenges here. These are mainly sort of non-legal challenges, but in some situations you may be able to deal with some of these within the legal documentation, which is why it's important to have it for certainty. But some of these things are just cultural changes that we'll have to get used to. The picture actually there is a building where I acted for one of the practices going in. The two practices had both come from owner-occupied sites, and it's that cultural change really of being like, okay, so this is going to be your part. How do the services work? How does that sort of sharing of space work? But this has been done with a lot of practices now. I was also advising a lot of practices in lift going into buildings with many practices in, and how was that all going to work? And a sort of a lot of concern about that, particularly if you've not even been involved in a lease before because you've been owner occupied. So I suppose my point here really is that it absolutely can be done. It's just people getting used to things like, oh, is this my room all the time? Is this my room, or is this sort of, is it being used for something else when I'm not here? It's making sure that you've got whoever's managing the practice, they are now a buildings manager, or maybe you need a buildings manager because suddenly there's the service charge and managing those shared spaces for the multi-occupiers and things like that you need to be sort of conscious of and aware of. And it's another role really in that way. But it absolutely can be done, and I've taken numerous practices through that process. You can go on to the next slide if you like, James.
Oh, thank you.
Thank you. I'm just finishing up really around this sort of looking to the future point, and I suppose not every we're talking about neighbourhood health centres. There will be neighbourhood health centres coming forward. It's going to take a while for some of them. New builds. We're talking about a sort of a new form of PFI. We will still need GP surgeries. That's absolutely the case. But I think it is worth everybody thinking about whether there's going to be a neighbourhood health centre near you, how that's going to look, how it's going to affect you, and looking at the building that you have, particularly if you're owner occupier, and thinking how can I make this fit for purpose for the future sort of provision of modern primary care? How does it sit within that plan that's being brought forward by the ICBs? Do we need to invest in the premises? There's another raft, I think, of the utilisation modernisation funding coming along the line, hopefully looking at some bigger projects. What's the appetite for risk in the partnership for doing something like that? Or if there isn't any appetite, the alternative to that is looking at, okay, how long is this building going to be needed for? What do I need to be thinking about long term if this was no longer being used as a GP surgery? And I think that's, although that sort of might sound slightly scary, I think it's absolutely worth thinking about ahead of time, because then you can be making sure that you have got everything that you need in your ducks in a row, I suppose, as you say, in terms of the property ownership. What happens when partners are retiring? Are you making sure that that's all up to date? Are you talking to your tax advisors about what would happen if I have this as an investment now and it doesn't become, it doesn't stay as a GP surgery? What happens around that? And I just think it's worth people having a think about that because of this sort of changing nature. It's going to be over a long period of time, but it's just something to be aware of. If you've got a lease, as I know James is going to touch on this as well, we always say ICB approvals, you've got to have them. Absolutely. But even more so, you don't want to be entering into a lease for 20 years and the ICB turn around and go, actually, we weren't envisaging having this building as part of the wider estate. We don't need it because we've got this, this, and this, and you must get the approval there. What if there is a new build neighbourhood health centre in your area? Well, there's going to be lots of opportunities there, and it will be interesting to see how this pans out in terms of what that means for local GP surgeries, and getting to grips with the guidance that's come out, working with the ICB and sort of knowing how that affects you. But I think it's a sort of a case of the more you know about it and the more you know about your own premises, particularly whether owned or occupied, the better prepared you can be to be able to take on the opportunities, and also be aware of the effect that it might have on the premises long term. That's me. I'm going to hand over now to James.
Thank you, Jen. So I will kick off my section by a brief talk about who BW Healthcare Surveyors are. I'll also probably mention who I am again for those who joined a little bit after I sort of started the meeting. I'll go through a little bit of a background behind the neighbourhood health sort of concept very briefly. I'll then go to some practical considerations that naturally occur as part of a surveyor thinking there's some several aspects through, and then looking at sort of considerations for existing estate as well, in many respects echoing some of what Jennifer has said during what she's already talked about. I'll then have a brief talk about look at some sort of floor space and usage considerations here. So in terms of who we are, I'm James Williams. I'm a director here at B2B Healthcare Surveyors. The firm is a firm of RICS chartered surveyors and registered valuers. We were set up back in 2017, and we operate entirely within the primary care sector all across England, Scotland and Wales, and we're a sort of a growing firm. In terms of the neighbourhood health concept, we're all aware about NHS England highlighting the need to transform the health system. Essentially, it's a fragmented service delivery, and the key issues we're all no doubt fully aware of. One key part of those are the condition and the inflexibility of the existing NHS estate, which is what's driven to a lot of these aspects. And a core part of the 10-year plan that was published last year places these neighbourhood health services at the heart of the reform itself, focusing on this shift from, as we know, the hospital into community delivery. So the rebuild programme, as we know, is looking to deliver up 120 of these health centres by 2030, with 250 by 2035. Whether these numbers change and shift slightly, we'll wait and see. But 80%, as I understand, of new builds proposed will be funded through these the public-private partnership systems of funding that are being developed. But in terms of the best use of existing NHS estate, this has been the key to delivery of NHS, the neighbourhood health centres. And touching what Jen mentioned earlier about the underutilisation of space, I think we've seen it noted somewhere, and I think it may have come from NHS Property Services, that some 60% of space is used ineffectively. And as also touched on, many GP practices that I visit are a lot of them are very incredibly busy. But if many of us who are familiar with NHS premises services estate, it may not be a surprise that some of it is actually inefficiently used. But that's perhaps a different question or aspect we're looking at here. So the first wave of 27 neighbourhood health centres are being rolled out within existing estate, will be delivered through a number of different models. So first we have the LIFT model and community health partnerships delivering 16. NHSPS are reported to be delivering 11 through a number of their properties, and also a third party landlord. I think PHP announced very recently with 3 to be delivered from their schemes. My maths isn't amazing, but that doesn't equal 27. But moving on swiftly, the neighbourhood health hubs, as we know, are designed to provide a number of community care services. Crucially, it is integrating care. So it's GPs, community nurses, hospital outreach, and various voluntary and community organisations. And as we know now that the minimum requirements set out is we're anchoring this obviously around general practice, this being the core model, and from which we're introducing these community health and these integrated neighbourhood healthcare teams, ENT, gynecology, community clinics, shared spaces. And the latest, I believe, the guidance is that they're to operate at a PCN scale, serve these population footprints of circa 50,000 with this 12 hours a day, 6 days a week operating basis, which clearly is talking to scale, isn't it? It's scale and a level of operation that is extensive. So in terms of practical considerations, clearly for both delivery of new space, but also within existing space, we're thinking this is considerable scale, and we're looking at the standard and the condition of the premises to be able to deliver these services from. Obviously, primary care, as a building primarily focused with delivery of primary care, is going to look fundamentally different, or could look different to a building that will be operating different elements from it, many of which can, and we're seeing many delivered how they should be delivered, but it could present, I think, operational design challenges that may require integrating different concepts within design. So Jennifer has talked about leasehold and sort of how the occupational frameworks could work with a combination of shared space concepts and exclusive use. But what I can see is that there will be a far greater emphasis, I think, on the shared space concept, the way I think NHS Property Services operate a lot of their shared functionality of their rooms within for other providers, which I think has been a great success, I think. So I imagine there'll be a lot of shared usage within the way that this will work. But how that sits within a legal framework and specific agreements that are entered into from an occupational perspective is another really important point to be considering, and in terms of the flexibility, but also how they're going to operate and what the liabilities will be, obviously. So in terms of practical considerations, as I've already sort of touched on, is design. So obviously within a primary care building, our staff and patient privacy is of a fundamental concern in terms of how they're designed. If we're looking at integrating different elements of community usage and other aspects that I think have been very successfully done elsewhere, and they can be done, it just presents another opportunity to think how we're taking into account elements of privacy, not only within staff and patient areas, but also within patient areas. You could have different uses that are adjoining one another, but potentially used very differently, that just need to be factored in and taken into account. And these, I think, are really important, such as patient flow as well within a building. We're looking at buildings of scale, certainly initially, and looking within the neighbourhood health concept. And the danger, of course, is the ability to lose people within buildings and make sure they're operating in a way that I think promotes the easy use of a building and promotes the right usage accordingly. I touched on about the impact on adjoining users, especially if you've got different types of usage taking place, and this ties in with the hours of use itself. We're aware of this 12 days a week, 6 days a week concept, but how will different elements be operated within that? Will it all be operated in that same way, or will there be different parts? And there'll be a way to consider and aspects to consider how they will then be operated and accessed if they're operating at different times or opening at different times. All really important considerations within something that I think would present very well, would work very well. And this obviously goes back to the shared facilities point that we were talking about, and common areas. Is this shared space primarily for patients, but are we also talking about elements for staff as well? How will they be integrated? So you therefore may be looking at taking some great existing examples, but may require elements of internal reconfiguration and design to make sure you're looking at space optimization of the whole and how it compartmentalizes as well. So I imagine there's a lot to have gone through that sort of process as well. I think security is going to be another fairly major aspect to be considered within these types of buildings, and you can also already see it within sort of lift schemes with how you have different users integrated accordingly. But you may well have to consider that there will be additional costs of ensuring patient and staff security within different arrangements and different uses that are taking place accordingly within these buildings. And it's important to be taken into consideration the management and as I think Jennifer already touched on, the management of these buildings, but also the monitoring of usage, to ensure that we're making the best use of the space and we don't end up with elements that do become underutilized. Because I think the danger is, obviously, we end up with something that is designed to be fully integrated, but ends up not being quite the case. So it's another important point. And the agreements, which have been talked about, how flexible or will they be, and what will they be looking like if we're talking about a structure where we've got a head lease system and then an under lease, or we've got a lot of sharing arrangements or elements of exclusive use. And I think it's really important to be looking at how that will be reflected, in how it's operated. It leads on to the question around sort of reimbursement systems. We have the premises cost directions within the primary care setting, and we're all familiar with how rent reimbursement is made. But how will that impact, and how will that be taken into account with effect to the way in which these buildings are used in terms of particularly shared elements? And Jennifer talked earlier about potentially sterilising or impacting elements that are not approved. It's making sure how that will all work. Will there be a head lease rent structure, or will that be more similar to sort of how lift buildings and community health partnerships works, with how those rents are based? And will there be a considerable element more reflecting a service charge aspect to look at covering the elements of the shared aspects, the utilities, building repairs and maintenance, security, and operation? And that may also have to reflect how heavily different areas are used compared with others. And I think probably service charge is one area where it could be considerable costs associated with how these buildings are managed. So it will be interesting to see how these are delivered, and these factors that are being taken into account in delivering these health centres from which we can integrate all these different uses. And as we've seen highlighted, these are very much capable of being delivered. It's just lots of various considerations around how these are implemented within existing premises. And most importantly of all, I also highlight this, I think in every talk that I'm doing, is it's engaging entirely with the commissioners and the ICB to secure approvals. And we're seeing the ICBs being in the driving seat for setting the plans and setting out the guidance around the pipeline for these. But it's engaging with those and how these are going to be delivered properly and fully supported. So moving on to some considerations around the existing estate for perhaps premises that aren't earmarked for the neighbourhood health concept as such, but that can take on board on a more micro scale the concepts of neighbourhood health. It's really important, I think, to be looking at making sure we make the best use of this estate by firstly looking at standard and the condition, where we can be making improvements, particularly around clinical space, around access, around the usage, to ensure that we're making the best use of that estate and we don't become unfit for purpose. We're aware of, and I think, again, Jennifer touched on the different types of funding arrangements that exist in terms of NHS capital, with another tranche of UMF funding going through, but also other forms of NHS capital and Section 106 funding. But also it's making sure we can stay on top of upgrades to premises, and we're making the best use of those premises, and that we provide the best, I suppose, patient experience ideally within them as well. Making sure we maximise the usage of space. Most surgeries that I visit across the country are always very busy, and most space appears to be being used, very, very well, because they're just so busy. But is the space actually being used in the best way? And in some cases, that might not always be the case, and we are, in many cases, limited by, in some cases, by the type of building that we're operating from. So you're only able to make certain changes potentially where you can. But in terms of certain areas, we've seen the evolution of things like patient records being digitized to create more space for more clinical space. But it's how this can be integrated and used, how we can intensify operations in certain areas. And if certain practices have a number of sites, how best to sort of allocate the usage of space within each site. And I think it's going to get more important over time as these aspects come online, and how we can integrate potentially other users within our own buildings. I've mentioned on the slide here, maximising sort of non-reimbursed space. And many surgeons will say, but what on earth is that? Because they get reimbursed for all this space. There will be areas where non-GMS space has been extended and hasn't been approved, or for whatever reason it isn't approved space, and it may even be lying empty. It's utilizing that space either through integrating another user or operator within the building, and this could be, for example, a pharmacy or a physio or dentist or some other operator, obviously making sure that we're not going to impact our own system of reimbursement that's been receivable. So we need to make sure that isn't the case. But if that space, it needs to make that space work for us. And that's either through integrating another use, for which, again, there can be a rental benefit with the funds available to benefit the practice itself and potentially the building. But also, but on the other hand, if there's been increasing in patients and we need to utilise the space itself, is there a case that can be made to integrate that space for the practice purposes now, to become clinical space, for example, or to become some other supportive function that could be used? Can we make the best use of this space and to make the space work for us? In premises where there are already other users or operators within space, where there are other leases, for example, it's obviously making sure as well that those rents are maximised, making sure those rent reviews have been actioned, and this is really to ensure that the practice and the estate itself is being managed to the best that it can be, so that the practice can benefit from the rental income, and those funds can be utilised again towards the building. So really, it's taking an overall view of: are we using everything to the best that we can? Are we maximising what we can? And do we need to do anything else to change what we can to utilise it even better potentially? I think all those things are going to be really important. And again, ICB approvals, if we need to be talking about additional space, if we need to be talking about changing the utilisation of space that may involve other leases or leasing arrangements, it's critical to be involved in the ICB. I still visit sites where and premises that have been extended. In some cases, years ago, that the commissions hadn't approved the space for reimbursement, and that space can't be reimbursed, or has been agreed not to be. And it's important that these things are looked at, and early engagement with the ICB is really important in that respect. I wanted to include a couple of just more visual slides just to break things up a little bit, and this is an example of not so much what the scale of a neighbourhood health sort of offering, but the utilisation of space within an existing surgery. So the top plan is an example of a floor used entirely by a surgery, and the plan below it was an example of where you might take another occupier, another utiliser, another operator who would take the area shaded in red. Now, the area shaded brown will immediately become shared space by virtue of that arrangement, and therefore any rental agreements that are reached need to ensure that that is reflected properly in the rent, and both that there isn't sort of an element of double counting taking place with any of that, but also that you don't sterilise the rental applied to that space. Both situations shouldn't occur, and obviously it's important for these sorts of considerations as part of looking at what is being used, where, and sort of how. There's another example of a building that might more sort of better lend itself to the scale of neighbourhood health examples that we're talking about, where in this particular instance you may be dealing with a primary care offering on sort of the one side of the building, but you can also provide elements of community care from other parts of this building fairly easily in terms of how this is designed, with sort of different modular access that lends itself well to sort of a permanent, generally open sort of capacity. But again, it's all down to the nature of that particular building and how it is used and the considerations around that. And that's all from my perspective. So I will just stop sort of sharing the presentation. I'll move over to look at whether there are any particular questions that have been raised as of yet.
I think you're very welcome to put a question
Absolutely.
in the Q&A, or you can raise your hand and unmute, and we're happy to have a discussion with you as well. I have been keeping there. I don't think there's anything in the Q&A and chat at the moment, but I'm happy to give you a couple of minutes. I think there's been a lot of information. So,
absolutely. And it's an area where we're seeing
that.
guidance developing and evolving over time, and I think we're looking primarily at how to better utilize existing space, but also making sure the estate is fit for the future, which tends at times it ties into these principles generally that we're seeing.
Yeah, and I think you're absolutely right to say, James, that the sort of the sharing, arrangement is likely if it feels very. Yeah, and actually, I think probably a lot of people are doing this already at the moment, aren't they? You know, that such and such a service is using that room on a Wednesday afternoon. And you've actually got a few different providers in the building, throughout the week, which is absolutely how it should work. But it's obviously just making sure that, especially where you own the building, you're protected around that, and in terms of recovery of costs and just management of that building, of people coming and going, is done in the right way. But it's certainly much more flexible than having a lease in place. But I guess the point to make sometimes as well is if actually that grows into then a certain provider is there all the time, suddenly you have got a lease situation, whether you call it something else or not.
And I suspect the model might change depending on which provider is delivering this and that arrangement, because if you look at the current plan to the first wave, it's three different providers with three quite different models of sort of operating and managing that estate. So it will be interesting to see where that goes in that respect.
Yeah, completely agree. And actually, I think probably one of the other points that's to touch upon is, we're sort of talking about sharing or subletting or using this underutilized space with other NHS providers, but actually I suppose the neighbourhood health ambition, isn't it, is to sort of go wider than that, and for there to be other public services and beyond utilising this space, so that users can come and access all sorts of different kind of services. So it's just worth bearing that in mind as well, and that sort of tips you outside then of the reimbursement question is a different question if you've got that kind of provider in as well. So it's just worth bearing that in mind. We do have a question now in the chat, looking to find out about charging. James?
Yes, I can't quite read. So,
you can't see it. Do you want me to read it out? It just says, I'm considering whether or not we claim rent reimbursement for the whole building, but sublet, but would not know how much to charge to ensure maximum income.
And that's, thank you for reading that. I think it's, in those situations, it's essential that you seek sort of professional advice on this from a surveyor initially, to look at how that can advise you and how that might affect your rent reimbursement. So it's important to look at, you can have a valuation done in potentially, which would involve a site survey, to look at how you're utilising the space, or how the elements would be sublet, and how that might actually affect your rent reimbursement as a whole, and the process you'd have to go through. So it's a fairly convoluted process itself, but also the level of rent that you could charge could be fundamental to that. So again, I would be recommending you get in touch with either ourselves or another firm of surveyors that would look at providing that initial information. It would then lead on to look at sort of in terms of rental levels, but also impact things like heads of terms for any subletting that might have to take place, that would have going to feed into solicitors that would advise accordingly. Yeah.
So no other comments or questions in the chat. Very happy if people want to pop their hands up. I think otherwise this has been recorded. So
Absolutely.
I think the recording can be shared, can't it, James? And happy to share the slides as well. And those have our contact details on. So appreciate you sort of listen to quite a lot of information. The whistle stop tour, exactly. And it may be that in the next day or so, a question pops into your head. Very happy to answer those questions.
I think with these queries, they tend to be quite specific generally, don't they? With it's building specific quite often, and premises specific, so I fully appreciate, don't we, that quite often you might want to be direct queries that you might want to share. So thank you all for attending and listening to us sort of go on a bit today. Thank you ever so much, and as Jennifer says, we'll send out recordings in due course, and thank you again. All right, goodbye.
Thank you.